Hello, my name is William Porter McRoberts, MD. I'm an interventional physiatrist, interventional spine specialist, double boarded, practicing here in Fort Lauderdale, Florida. Today I'm going to talk to you about lumbar spinal stenosis. This is a video for you if you are someone who's suffering from this or been diagnosed with it, so that you can better understand it, understand why it happens, why it's bothering you, why it affects you, what the current treatments are. This is November 24th, 2024. What's coming in next year, 2025. And what are the risks and benefits with treating it, the various forms of treatment, the minimally invasive techniques, the open surgical techniques, the ultrasonic or harmonic scalpel approaches, and what the history's been and what you can do, and how to make a decision about what type of surgery to have, how to pick your surgeon, and what are the consequences of a surgery, a botched surgery, or quite honestly, what are even the consequences of doing nothing, which is actually quite impactful as well. So we're going to start by first defining what is lumbar spinal stenosis. It is a condition that is a function of narrowing inside the spine. You can see this is a model of the spine like so. It is organized in such, it's pretty simple. It's kind of organized. I'm facing the same direction as this lumbar spine, but you can see discs and bone in front. And then you see the canal in the middle, which is where all the important nerve roots and all the important neural elements are. And then in the back, you see the spinous processes, the transverse processes, sacrum, etc. This is where all the muscles lie. And this is the structural integrity of the spine, as well as the movement of the spine, is controlled in the posterior aspect. So the first step is, what is spinal stenosis? As you can see, you can kind of look through there, the canal, you can see the nerve roots, but you can see these holes through here. That canal in the middle, about the size of a test tube or your little finger in most folks, is where all the neural elements lie. And you can see on this MRI that this is where all the nerves that go to your legs exist. The way the spine is organized in terms of the neuroanatomy is such that all of the nerves, which essentially go for anywhere below your belly button, are contained within the spinal canal. And any impact within the canal, any narrowing within the canal, starts to impinge upon those nerves. And as the impingement gets more severe, as the compression of the nerve roots becomes more severe, and it's a dynamic thing, then you start to experience what we call neurogenic claudication, which is essentially the feeling of heaviness or tiredness in your buttocks, your legs and thighs, and it depends a little bit on where the stenosis is, but then also sometimes even your low back. It is accentuated by walking and standing. It is relieved by sitting. And the reason is because as the spine moves, when we sit, for example, what happens as we sit is the femurs, which are attached like this, they rotate in that fashion. And so as we sit, we bring the sacrum down. We actually increase what is known as the lumbar kyphosis, which actually disimpacts the canal. And as we stand, then it starts to compact the canal and start to pinch in on the nerve roots even more, which is why the hallmark of standing and walking pain being so significantly correlated with lumbar spinal stenosis. I've always said this is something that almost anyone can make the diagnosis if you simply listen to the patient or listen to yourself. And if your pain is in your buttocks and your legs, especially with standing and walking, well, it's a very, very high degree chance that you have lumbar spinal stenosis as the primary cause of your pathology or your pain. The treatments for that are changing and getting vastly better in the past even 5 years. We're going through a revolution in what is available and the safety aspect of doing this treatment, somewhat akin to the advent of stents and angioplasty in the heart, as opposed to open direct cardiovascular decompression with vascular reanastomosis. Essentially a cabbage went from open heart to simply putting in stents, and that's similar to what's happening today in 2024 and 25 with the spine. Similar in terms of the safety profile, similar in terms of the outcome. And the question then is, how do you know if you are a candidate for this treatment? There is another video I am making on how to read your own lumbar spine. I think it's worth watching. I'll make that available soon. This actually, just a plug for this video, actually talks about all the pathologies in the lumbar spine, how to understand which of the things are affecting you, and what are the available treatments for all the other conditions of the lumbar spine other than just lumbar spinal stenosis. But this video is about lumbar spinal LSS, for lack of a better long term. So we understand basically as we stand and walk, the nerves get compressed, and that is the pathophysiology, that's the mechanism. As those nerves get compressed, and I've said in previous videos, the perfusion pressure that's the amount of pressure within the arteries, the smallest little arteries that are delivering blood to those tiny little nerve roots. You can see each one of these lines is a nerve root. And so you can see here in this cross section, each one of these little dots is now a cross section. It's like looking at some spaghetti is a nerve root. And each one of these nerve roots has their own various tiny microscopic blood supply arteries. And as the compression supersedes the perfusion pressure, kind of like if you're standing on a hose, and the hose, at a certain point, you get a fat enough person or heavy enough person, you know, that compression of the hose will supersede the ability of the pressure from town hall to essentially drive water through the hose. The same thing is happening in your nerve roots. And these bulges that occur for a variety of reasons will start to compress the nerve, the blood supply to the nerve. And in so doing, you'll have a feeling of deep, achy pressure within the legs. And as soon as you sit, you disimpact that. You take the pressure off, the blood flow restores, and thus not necessarily the feeling, but the innervation of the muscles of the legs and the skin, etc., all returns to some degree. As the disease progresses, even sometimes folks have little recourse even with sitting. And so their disease progresses to such a degree that they have profound pain sitting, standing, walking, in any position. Nevertheless, the hallmark is standing and walking. So let me just explain briefly the MRI and why it matters to you, and why the MRI, in my opinion, the digital autopsy, as I call this, paramount in understanding how you may or may not fit within the various protocols and paradigms for doing this minimally invasively. There are 3 general approaches to treating this. I'll add 4, but the 4th is physical therapy, and I've found that physical therapy just simply isn't robust enough to have an impact for most people. I've had 2 patients I mentioned previously. I've had no more since that video who've gone and done physical therapy. These were physicians who just went crazy doing crunches, trying to change that natural lumbar lordosis into a kyphosis just by tightening the abs. They did 500 sit-ups and crunches a day. They both were successful, but nevertheless, I've not had anyone who's ever been able to replicate that. But this is about position, this disease. So the MRI. The MRI is the digital autopsy. It shows us your neuroanatomy, and I'll get into a little bit of that in my other video. But there's 2 basic cuts that we get, what we call sagittal cut, which is right down the middle. So right down this side, and this is from your side. This is me facing you, or spine's facing you. This is looking at the back of somebody with a various amount of interspinous spacers or posterior interspinous fusion devices implanted. And so we get a slice that goes, this is the principal slice, right down the middle, and that's this sagittal T2 image. T2 allows us to see the cerebral spinal fluid, fat, and the morphology of the bone, the disc, etc. So we'll zoom in on that. So here we are looking at the same projection. So the slices, as we talked about, are like so, overlaid. So skin, subcutaneous tissue, spinous processes, canal, impasse, obviously, disc, bone, disc, guts, vena cava, aorta, etc. out front. So the first thing we see, and we can come back and we can see that we can go back and forth in this projection, going across the slices. And you might notice, actually on this here, you see this blue line. This blue line is the scout line for this image right here. So as we bring this image to the middle, and we'll try and do that now by bringing that blue line right to the middle, we're really seeing an appreciation of the canal in the midline. And we can see in this particular patient, who is definitely suffering, we see a few things. One, we see straightening of the. Number two, we see ligament. And then we also see posterior disc bulge, a little bit of what we call anterior listhesis. This bone is slid forward, but it all contributes to an overall dramatic narrowing of the canal. Now, let's go back over here. Now, once we go over here, we see these are axial cuts, which are made slicing like so through the spine, kind of like a guillotine. Now, this one up here is going through the 2-3 segment, and you can see this canal correlating here is open, and the nerve roots are surrounded by cerebral spinal fluid, which is like water, like little spaghettis I always explain to patients. And as I bring this down, you can see that that canal remains open. The blue line is over here. I'm going to bring the blue line down to our area of interest, our stenosis right here. So as we bring this down, down, you start to see that the canal gets very, very narrow. And you can see with complete occlusion of the canal. And that's why this poor fellow has been suffering. This is actually a preoperative MRI that I took prior to his implant and his surgery. And so that contribution overall of the ligament and the facet joints right here to the overall stenosis is why he's suffering from spinal stenosis. Now, interestingly, this was a lying down MRI, which is akin to the same position as standing. And so when he sits, this would look different. And a sitting MRI doesn't actually show the stenosis to the degree that it's generally affecting people as they stand and walk, which is why, one of the reasons I don't particularly like standing MRIs per se. So there's really three types of stenosis. There's central canal stenosis in the lumbar spine, which we can see here. This is central canal stenosis. And then if we bring the slice over here, we can, to the side, we'll notice even what we call lateral recess stenosis. And lateral recess stenosis, and I'll show you in a minute, is deep to the facet joint itself. This is the facet joint in the back on each side. And so there's in the canal, and then this midline area is lateral recess, is what we call it. And you can see in this particular person, he has, in addition to central canal, there is lateral recess stenosis. We can see that in here. The reason I make this distinction is there's something called a mild procedure, which allows us to remove part of the ligament inflavum here, but not underneath the joints. And so when we first brought this procedure out, and we were lucky to be one of the sites that brought it through the FDA process, but the ligament inflavum here in the subarticular recess, the lateral recess stenosis, cannot be addressed by mild. We could only treat what's right here. And so that is an incomplete treatment for this particular patient. Now, it might be enough, but it is incomplete, so to speak. So that's the second type of stenosis, central canal, lateral recess. And then the third type of stenosis, which affects people, is something called foraminal stenosis. And you can somewhat see it in this patient. Foraminal stenosis is the hole or foramen or window in Latin. And you can see this is a normal open window. There's the nerve root, there's the fat surrounding it. Same here, pretty good, lots of fat. Pretty closed here on this left side. Not as bad as I've seen by any far, and pretty open. That smudge of dark is the nerve root, and the lighter gray is the fat surrounding it. And we can see, and his hallmarks were bilateral pain in the legs, but worse on the left than the right. This also is something that cannot be addressed by posterior approaches to decompression, such as mild and even laminectomy, cannot address a foraminal stenosis. All right, I'm going to discuss things in order of, okay, so I'm going to go in order of invasiveness. The least is mild and appropriately named minimally invasive lumbar decompression, sometimes too mild, in my opinion. But mild was conceptualized about 10 years, 15 years ago. We were the first in Florida to do mild. Mild is a way to, and at the time we really had no posterior inner spinous spacing or no way to physically decompress other than to remove ligament using surgical techniques. And the problem was getting there was hell. Big incisions, lots of bone removed, destabilization as a result, fusion required as a consequence. And then we had epidurals on the other side, which leaves a lot to be desired. So mild was the first really minimally invasive way to address the cause of spinal stenosis. And it worked by removing what we call redundant ligamentum flavum, which, as I described previously, there's three types of stenosis. One is the foramen, the hole where the nerve comes out. The second is in the lateral recess. And the third, the most important for mild, is where we have redundant ligamentum flavum. The ligamentum flavum really serves minimal purpose, and as the spine shrinks, you can imagine that the ligaments within inside the spine, as they shrink, kind of like if you lose a lot of weight, your belt becomes redundant. And as these discs shrink and lose volume and height, the ligaments start to buckle and they compress inside the neural elements. So, and you can see in this case, this ligament right here, that black, which just looks like the back of the disc, that's really the ligamentum, that's actually posterior longitudinal ligament. Ligamentum flavum is right here. Here's some ligamentum flavum hypertrophy. You can see he's lost some height in this disc. And then this one is shifted forward. That black bulge right there is ligamentum flavum. I wish I had the tools with me today. I don't have any. They're disposable, to be honest, but I've kept a few. But there's two essential tools to mild. And the way I do mild, and I think it's by far the safest way to do mild, is under local anesthetic only. The reason being, I would say the patient is the most sensitive neural monitoring piece of equipment in the room. We don't have to do SSEP or monitoring. We simply can talk to the patient. And if we keep the patient awake and conversant, then they can tell us when we've become not mild enough or too aggressive. So there have been a few cases in the past that have had some complications with mild, and this, in my opinion, is because the patient was put asleep. General anesthesia has been used. It's certainly easier from a perspective of just not having to deal with talking to the patient. But you lose that feedback, and that to me is everything. The more I can communicate with the patient, the better they're going to do, and the more aggressive I can be. The way we do the local is very easy. We do what's called a medial branch block. So we numb the innervation. We just use a little 25 gauge needle. It's just like Botox size practically. Come down here under x-ray so we can see everything. And numb up the innervation of all the bone and ligament of the posterior aspect of the spine. We do not numb up the nerve roots, which we see here. So those are perfectly sensate. The patient can see or can feel those rather easily. They can feel their legs and feet as they should, but they cannot feel the work we're doing. It just feels like dull, achy pressure, not even dull, achy. It's just some pressure, very tolerable. But what we're allowed to do is then, with our instruments, we make a little incision through the skin. We pass what's called a working trocar down to the bone. And then, and this is smaller than a number 2 pencil, significantly smaller actually, we reach into the spine at an angle and we remove, under x-ray, we're watching the ligamentum flavum. Now, we're limited because x-ray does not show the 3-dimension that MRI does. And so we're doing it a little bit by just where the architecture is and a whole lot by feel. And that feel component is what I think allows us to be somewhat successful and why you want someone who's done a few, as opposed to someone who doesn't do many or hasn't done them at all. Because that feel component, now we're grabbing soft tissue, and what is deep to this bulge is the entire neural supply to everything south of the belly button. And there's a lot that matters south of the belly button to a lot of people. So, you know, if you happen to grab one of these nerve roots, patient's asleep, doesn't realize it, you pull it out, well then bad stuff happens. You know, you'll have pain down your leg, you'll have foot drop, you'll have incontinence, and it gets worse from there. So the key is keeping people awake. If you do that, the likelihood of a bad neurologic outcome is very low. But, and quite honestly, if we look at the open surgical series, you know, the complication rates are in the 10 to 27% rate, which is massive. But with mild, it's under 1%, even done with sedation and done with general anesthesia, which means done awake, even lower than 1%. But one has to have central canal stenosis as a function of the ligamentum flavum hypertrophy, because that is what we're removing. We cannot get underneath these facet joints. We just can't do it. We can't go laterally. As we do, we start to get close to nerve, and we surely can't get to the foramina where the nerve comes out. Mild is limited to only ligamentum flavum hypertrophy. And as we've got better at reading MRIs and understanding the limitations of mild, I think the success has gone up. In our practice, I've actually reincorporated mild because of that. And I think that people are doing pretty well. Nevertheless, I'd say the success rate in my hands is around 50%. 50% ball leaves the park, 50% it's a grounder, and really nothing happens. And I always say spinal stenosis is a disease of millimeters, and 1 millimeter matters immensely. More or less, and you have compression of those arteries like we discussed previously, and or not. So that's mild. Mild's outpatient, takes about 20 minutes per level, really. I mean, it's very quick. You go home, keep an eye on things afterwards, talk to your physician, etc. Make sure you have a phone to call if there's any complications. Sometimes you can have bleeding in the canal, which needs to be decompressed thereafter. That's why good communication is paramount. So, all of these things, and I don't have a Vertiflex, but that was the first one, came to pass because mild was too mild, just didn't seem to work as well as we'd like. And of course, our major competitors, neurosurgeons and orthopedic spine surgeons doing lamine fusions. It behooves us just simply talk about what that is. What is a laminectomy and a fusion? A laminectomy is the removal of the lamina, which is, I'll just show you here, this right here, this spinous process is connected to this bony element on both sides, and then the pars is this connection of bone right here between the pedicle and the transverse and the superior articular process. That pars is cut, and in the cutting of the pars on both sides, we can then remove essentially the roof from the room or the house. And as you can imagine, that provides an enormous amount of room. So here we would remove the spinous process, remove this spinous process, and then also the ligament and the joint and everything would come with it. The problem is, as you can imagine, once you remove all that bone and all that ligament, etc., now you have no more attachments or minimal attachment for the muscle, and the spine becomes floppy. The discs, which have very little structural integrity, their main job is cushioning axially. Fatigue and fail, and pain ensues. And so the consequence of that is a fusion. And so it's come to pass that in America, at least, we generally do the laminectomy and fusion together, because we know in people who have a laminectomy, at least 50% of the time, they're going to have instability at that segment, and they're going to be right back in the OR in months to a few years. There is, interestingly, quite a few people who seem to do well. These are older folks who they're not out playing pickleball or racquetball or skydiving, and they just need decompression. They actually seem to do pretty well because they're not making demands of their spine to a large degree. But the negative of fusion, why is all this, why are we trying the minimally invasive approach? The negative of fusion is that fusion then puts additional stress, significant stress, on the adjacent disc above and below, because in addition to fusing now with the pedicle screws, we put a piece of bone between the disc and the anterior column here. The disc is removed, bone is placed, and these two components, as well as these components, are then fused. The purpose of the hardware is to hold that construct in place while it sets, and you fuse together, the bone unites, and you now have good bony union, but it takes several months. In Japan, Asia, Europe, for the most part, a second surgery is planned where they remove the scaffolding, so to speak, as the integrity of the spine is good, and that's somewhere in 6 months to a year's time. It's thought that some of those metallic implants rub on the muscle, cause pain of their own, etc. But nevertheless, if we fuse, the next segments now have to do much of the work, and they will also degrade at a vastly more rapid pace. And so imagine if you're kind of aging in dog years above and below your fusion for every human year you're living, because you're robbing the adjacent segments. So those have been the problems of what is still done today, open surgery of the spine. So this next step, if we can't do mild, what do we do? And the next thing we do or consider for most of us, and I will tell you, this is still an enormous point of contention between orthospine neurosurgery and interventional spine physiatrists and interventional anesthesia and radiologists who are all doing this posterior interspinous work. But the next step for us, at least, and in terms of my thinking, the next least invasive approach is posterior interspinous spacing, or quite honestly, posterior fusion. Initially, what was called the Vertiflex was true interspinous spacing, which is an injection of an implant. We numbed up the skin, made a small incision, dilated the spine, which was usually kissing at that point, and then put a little spacer. And as we dilated, opened the interspinous space, we put in a little, it looks like an X-wing fighter that just sat in here. It was not bonded in any way, which is actually its ultimate downfall, but it did space it. And the problem ultimately with Vertiflex was twofold. One is that it could pop out, which occurred probably 2 to 3% of the time. Never forward though, thank goodness. But the other thing is that the way it was made is that there was essentially a 2 millimeter construct of metal, titanium, which would rest against the bone. And as patients go and walk and live and fly and do all their grandchildren, etc., that titanium wears into the bone, and the bone sinks and subsides into the implant, and thus the lifting capacity of the Vertiflex fails over time. And that failure rate is somewhere around 50 to 70% now in my patients. And we've revised quite a few to these more robust constructs, and also many have gone on to have frank open spine surgery as a consequence. Okay, next is interspinous spacers, or interspinous posterior interlaminar fusion. And I use the F word cautiously. I call it a soft fusion because it is materially different than a normal fusion performed by anteriorly by an orthospine or neurosurgeon. But it is indeed fusion, because we are now fusing the posterior elements, the lamina and the spinous process together, and it does move in concert. But the main impact, as you can imagine, is if you're looking at this MRI, if we go in right here and we dilate open, and we can do it either through a posterior incision open or through a lateral incision over a guide wire, which you've seen probably in some other videos I've shown. But if we materially open and force open the spinous process, we have as a result three things. All three areas of spinal stenosis are decompressed substantially. Certainly the ligament flavum becomes tight and taut, and the mass effect on the nerve roots goes away. The lateral recess, as we discussed, those bones get stretched, and the lateral recess gets substantially decompressed. And in addition, something I really didn't appreciate when I started doing this, the foramina, which had been the Achilles heel for many, even neurosurgeons, is adequately decompressed. I'm going to take a small sojourn and tell you why, and one of the critical parts of open surgery, the foramina, and getting there. And this is one of the criticisms that's been leveraged and thrown at this ultrasonic scalpel, harmonic scalpel approaches. It's still open spine surgery. There's still big incisions. There are, even if you use a MedRx tube and you do tubular dilation, down, you still have to get to the areas where you use your minimally invasive harmonic scalpel. The minimally invasiveness of what you're doing down here may be small, but however, the access is large, and that requires a lot of cutting of bone and of facet joint, et cetera, to get there. And so when it's been said, we just remove bone, the bone is what gives the structural integrity to the spine. Without it, it's just a noodle. So, but you can see getting to the foramen, you really can't get from the side very easily. It's simply too anterior. We've got kidneys sitting here. We have the nerve roots coming out that then come around and wrap and form the lumbosacral plexus. So getting intraforaminal has to be done posterior-laterally or posteriorly. And that requires essentially removing the facet joint. And once you remove this facet joint, whether you use a harmonic scalpel or a burr or a rongeur, whatever it is, you've now destabilized that section, and the gliding and all those things are gone. So that's where, and I call them the Michelangelos of spine, and they're few, but they exist. The guys who can see it in their mind three-dimensionally make small portals and go in and then simply remove using small access, small minimally invasive, small access approaches. They are very rare in the world and certainly in the US. And sadly, hard to find because you don't know. It just says neurosurgeon on the front door. You don't know who this guy is, sadly, or gal. So, to be able to open up the foramen for us is huge with this posterior minimally invasive 30 to 45 minute approach for the placement of the spacer. There are two ways to place spacers. I don't have a Minute Man. Nope, I do have a Minute Man. Hold on. The Minute Man is the only true minimal access approach, and this is the Minuteman right there. And what it is if you look at the bolts, the molly bolts you put into drywall, these little things pop out and we deploy them. So what we do is we start from the lateral position in the flank. Now we are posterior to here, so we don't have to worry about the nerves. It's super safe. We're doing it under x-ray. Put a little wire, a little needle down first just to numb you up. This can be done awake, asleep, whatever you like. Put in a little wire. Over the wire, we then use a series of tubular dilators that simply stretch muscle as opposed to cut it. And that stretch muscle allows us a little tube of access. And then we take this thing, we go in and we measure. And I actually show you on this patient, that's what we did. You can see here, this little, this is the guide wire, that's my needle. This is a cross-sectional approach. Then you can see there's the tube, I put the tube in here. This is the dilator and actual measure all in one. This is at the 4-5, and this is this is his MRI, this is the patient. And so this, you screw it in, and as it does, you measure, and it actually opens up, widens the interspinous space as you're doing it. And then this is the implant going through the tube, now with the interspinous process is widened, and we simply screw it in. Again, patient can be awake or just asleep or very comfortable. Lateral approach, and then deployed. And here is the implant with the wings opened, just in the same way, and then fully deployed. 30 minutes, in and out, minimal blood loss. What's the downside? Upside is, of course, you get posterior compression, posterior lateral compression, ligamentum flavum decompression, and foraminal decompression. The negative, in my mind, is, and it's about 20% of the time, not enough. Just not enough. And the not enough is that if you open this up and you still have redundant ligament, you can't really see dynamically. And this, I've had about maybe a 20% failure rate. And when I say failure, I mean 20% didn't get 100% relief. 80% get 100% relief. which is astounding, actually, when you think of it, because a knee replacement, 87% are pain-free at 1 year. Spine surgery, I don't know a comparable spine surgery that has 80%. And there's actually better, in my opinion, than 80. But nevertheless, 80 is pretty darn good. And it's not that anyone's worse. And that's another key, is that when anyone is thinking about surgery, you think about what percent get better, and then you think about how many stay the same. But a consideration is what percentage of people are worse. And of the knee replacement literature I just cited a minute ago, 13% are worse. In a hip, 8% of total hip arthroplasty at 1 year are worse than they were prior to the surgery, which is substantial. That's going to Vegas. And when you lose a lot. So to have a procedure, and I'm not trying to sell, I'm just simply trying to tell you the pros and cons. But when you have a procedure when the chance of worsening is super low, I've never had someone worse. I've had them not better, but never worse, is low, and there's a fix, and the fix is obviously not what people want. But that type of gambling is a lot better. You're really gambling with someone else's money, in my opinion. So that's the Minuteman. Great procedure, super easy to do. Then as you screw down this nut, it secures the device. There is no way there will be subsidence in time of this device. And we put bone in here, and we actually cause a fusion between the lamina on each side, above and below, and the spinous process. In a couple of months, this is an extremely rigid construct. You can go back to golf, you can go skydiving, you can do whatever you want, pickleball easily. Great procedure. But one other caveat I might add, we simply can't get down here to the L5-S1 because this part, the ilium, the hip bone, in men is quite high, and women is still too high. And you can see this little angle. I had to take that angle, I had to make it over the ilium here. And so to get down here at the L5-S1, it's simply not possible without a posterior incision. So what's the negative of the posterior incision? After you've done a lot of them, really not much. People do really well. So that's what's, if anything is growing in 2025, it's adjuncts to the posterior approach and filling out the spectrum of different things that we can do posteriorly. So let's go to that. I'm going to jump in one thing that's is missing, and that is a facet fusion. A facet fusion is, let's see if we can go back to the axial cuts. So there's facet joint. What if we place the patient in the position where the facets are open, in the same position we're trying to achieve with these interspinous devices, and then we just simply fuse the facets? So this is true fuse. It is one of quite a few approaches. Some are bone, some are metal. If you can do a facet joint nerve block or intra-articular facet injection, you can do this procedure. This is another can be done while awake approach. What it is you must put the patient in flexion, and that's the thing that's most challenging, even with what we call a Wilson frame, which is where you lean over, you bend over a pillow on the OR table. But even then, it's hard to achieve that sitting position in the OR, and that may be one of the limitations. The other limitation is that when the patient stands up, that's not a lot of construct to hold them in position, and a lot of them will cinch down and then fuse in the cinched position. But nevertheless, this is, talk about minimally invasive, and this is certainly something that one can try, and having failed to go on to these other constructs, I throw that in as a consideration. It's something I've done. I do it. I find its utility and need rare because these others seem to work so well. So let's talk about posterior approaches to interspinous fusion. So here's our three. These are the top three in my opinion. This is called a zip. Why is it a zip? Because you got to get it there somehow. So what you do is you make an incision over the skin, you dilate the muscles, you remove the muscles from the posterior spinous process, not the transverse process, not the facet joints, and you move them aside. It's easy to do. Again, this I do have to put people to sleep though to do, but again, it's not a big deal. And the reason, I feel comfortable doing these under general is because I'm not ever getting close to the neural elements, not at all. It's just virtually impossible. So my degree of confidence is much higher in this for not causing injury, which again is one of the main things. If you've got a 27% complication rate with open fusion, etc., that's key. And there is a time you need to do open fusion. We'll talk about that too. But with this, you make an incision, you go in and use a sizer, and the sizer dilates, and we can dilate that open, we can measure, and we can actually see in cross-table lateral on x-ray how much dilation we're doing. Then we appropriately find the size. Then I grab, they bring a bunch of these to the OR, one that's appropriately sized. I slide it down over the spinous process, and I snap the thing together, zip it together, and we have a little bone, we have some grabbers. Those little tiny spikes, I don't know if you can see them, they actually go into the bone, securing the device. Again, no subsidence over time whatsoever. And then you simply irrigate and close. The muscles will adhere, and I've done revisions on some of these and added spinous additional spacers above previous fusions and below. And you find the fusion has integrated into the bone near completely, and the muscle has reattached actually quite well to these levels, which allow for motion above and below quite readily. So this, in my hands, is closer to a 90. I hesitate to say it because I don't think I've had really anyone who isn't substantially better, if not completely better, using the zip or a posterior approach to interspinous fusion. And so that's saying something. I say it very cautiously because of course different hands have different experiences, etc. And maybe I pick the patients as well as possible, and if you only swing at easy pitches, then your batting average really goes up. But I try and swing at easy pitches. So an advancement to this zip is what's called the Zip 51, and you see this down here at the L5S1. This was previously a very difficult level. I used to do the facet fusion here at 5.1 because I could get to it. But I couldn't get to it using the Minuteman or any other approach until we came up with 5.1. Now, 5.1 is interesting. Again, Aurora makes this, and they're a great small little company on the Canadian Stock Exchange, actually, which is kind of funny. But if you look at this one, it's hard to really see, but I'm gonna try and show. You see the canting of this, and it's actually best like this, what we call praying hands. This actually attaches readily. And those little spikes, there is a spinous process, but it's a tiny one at L5S1. You can see it, it's tiny. Nothing like the L5. Here's the S1. So grabbing that and getting purchase on that is somewhat challenging. This device does it, and it does it really well. And the reason is because it approximates the angle of that, and then of course the spikes slide in very easily as we zip it together above and below. So that's the Zip 51. Totally opens up this as an option for this level, the L5S1, which is probably 20 to 25, 30% of the time. The gross majority are at L5S1 by a long shot. 3, 4, but I've seen 2, 3, and I've seen 1, 2, and even T12L1. But this approach is pretty good. Not pretty good, it's amazing. I'm gonna talk, I'll talk a little bit more about that in general next. This is another interspinous device from a company called FlowSpine. This is just out, just available now. And the idea, and what we don't have is there's another piece that goes on here, which makes it a little larger. But if you can see, it goes pretty ventral. And when we say ventral, we mean anterior, closer, deeper. And there's a little screw right here. That screw allows us, using a little Torx wrench, to advance a bit, a chalk, so to speak, if you're into rock climbing like I was. And that actually physically expands the device, and it's placed more anteriorly. More anteriorly means that we're not resting on the inner spinous space, but we're really truly resting on the lamina, which allows, and if you look at the physics of it, it's why a teeter-totter, why a mom with one hand can lift her kid at the other end. She's got leverage. But we lose some of that leverage as we go anteriorly, which is a good thing in a way. And so then the amount of leverage and force being placed on the device is less, and the bone needs to be less robust, which is important in osteoporosis, than it does with something like this, and certainly something like the Vertiflex procedure, which is really quite posterior. So we're getting more anterior. What are the negatives of this? Well, this particular device, they're onto something. But what you don't see, and I wish I had it, there's another, the FDA thought these wings would pop off, and they required a clamp to go on. The clamp is a fairly large, clunky looking device, but it's required in order to place it. But now you're going anterior. You're also getting closer to those fabled nerve roots that you're trying to stay away from. So it's a little dicier. You got to remove more ligament inflatum. So we're using a little Lexauer rongeur or a Kerrison to get down in there. So we have to remove a little more ligament. We have to dilate a little bit more. It does dilation itself. We have yet to see really what will this be? 2025 will tell us. We'll see. 2026, maybe even more. Very few people are doing this now. Very few. But I think it'll gain more acceptance in time. So why wouldn't you have this? It seems like I've talked it up, and I have great faith in it, but not in everybody. We're not going to fire the neurosurgeons. They're incredibly important. We need them. They're very useful. They're doing great work, and we still need them. And why do we still need neurosurgeons for lumbar spinal stenosis? And here's why. There's several reasons. One, these don't always work. What we do as interventionalists don't always work. We still have cardiothoracic surgeons opening and cracking the chest and doing coronary artery bypass grafting. We still need neurosurgeons. But I think for garden variety spinal stenosis, this is an amazingly effective, minimally invasive approach. But why do we need them? Well, sometimes you don't decompress enough. And what's the next step? You got to take that baby out. You got to take this thing out. That requires laminectomy. Once it's in there, there is no soft, easy removal. I mean, maybe in a week or 2 or 3, but after a couple months, there's no way that's coming out. I've seen it. It is integrated. It is swallowed by the bone. So in order to remove it, you've got to do the laminectomy, which is what you're trying to avoid, but nevertheless, it is and has been the standard of care for 50 years. So you're simply doing the standard of care to move on to the next step. This does not burn that bridge. None of these things do, which is a plus. So you still have spinal open surgery as an adjunct and a fallback with these. So what if you do have osteoporosis? This is a toughie. There is no definitive, we're at the edge of knowledge. You can't ask AI. AI will not tell you. We don't know, AI doesn't know. What is an appropriate score? How does the flow spine change it? Does it actually change things? It does conceptually change things because you're going more anteriorly, you have stronger bone. So have you had spinous fracture? I have had spinous fracture, process fracture. I just simply braced the patient and she did great. So that shouldn't necessarily be the fallback. That was a good outcome. But generally what we do is we brace them just like they have a spinal fracture in the first place. Now, what is lost is if you have the fracture, in the same way the vertiflex has subsidence, now you've lost the height-producing effect of the interspinous mass. But it's not terminal, you haven't had a catastrophic outcome. And again, if you don't get the relief in that spinous fracture, process fracture, then you need to go on. Could you also then do a facet fusion? You could. But again, you know, that's, again, if you have to stay minimally invasive, if you really want that, you could do an adjunct with the Eon or the True Fuse and place those little inner facet devices. Actually, it's called an Ion. I misspoke. What are other negatives? I don't know. And this gets to the, let's pull back and talk about just, you know, where folks are in life with spinal stenosis. There's a fascinating paper that came out exactly 1 year ago, actually. It's in November, it's about October, actually, of last year, 2023. And it was a big prospective randomized trial. And it was simply observational, but it was so massive. It was hundreds of thousands of patients followed for about 7 years. And the question was, how important is walking? Hippocrates said walking is the key to life. It's the supreme medicine. He's absolutely right. I mean, if there is anything that we know, that the aging construct of the human animal is dependent on walking. And if it doesn't walk, it ages in dog years, like I said previously. If you're not, like sadly, my own mother can't walk right now, but she is aging so rapidly and degrading over time. If you can't walk, and let's say the rest of you's fit, but you can't walk because of lumbar spinal stenosis, you are degrading. So this study explored exactly that. And how important is walking? What it found was that 1,000 steps per day, 2,000, 3,000, they subdivided into 1,000 steps. If you plus or minus that 1,000 steps either increases or decreases your risk, all-cause mortality by 15% for every 1,000 steps taken or not taken, a plus or minus, which is massive. You think of you know, most medicines we take, we're simply nudging the needle. Walking is the key to life, not only for your muscles, not only for your mental health, not only for osteoporosis, because just 3 miles a day is the same as taking a maximum dose of Fosamax, for example, just 3 miles of walking. But it's good for all of us, cardiovascular health, atherosclerosis. The entire animal needs to walk and move. And if you can't do it, and that's the whole point of all of these things, is we must regain the ability to walk. As we age, simple things like shopping, going to Costco, you know, getting the mail, walking the dog, these are the things that preserve the next decade and the decade after that. And if you can't do it, then you've got to measure what is the risk of doing something about it versus the dramatic, incredible risk of doing nothing, which is, for every 1,000 steps, a 15% increase in your chance of all-cause death. 7% for cardiac mortality per 1,000 steps, which is shocking to me. So this is an overview of what's available to the interventionalists, and not all of us are doing this stuff. You know, I'd say 1 in 10, maybe 2 in 10 are so inclined to do this kind of work. But I think it's transformative. I think it is the advent of a new field, to be honest. And in 10, 15 years, just like interventional cardiology is going to be, or was different with balloon angioplasty, et cetera, interventional spine in the lumbar spine, and soon thoracic and cervical, and we can talk about that in other videos, is going through a renaissance. And the rapid, almost monthly rollout of various techniques and devices is awesome. All inspired by a reduction in mortality, a reduction in complication rate, and an increase in outcomes without being out the big knife and cutting through irreparably bone, ligament, tissue that can never be repaired, and for which patients are unalterably changed forever. The whole spinal cord stimulator debacle, and I call it debacle because what is it for? It's for dealing with debacles of massive surgeries, massive fusions. That whole industry exists largely because fusion just didn't work. And it's an amazing thing to me. It's kind of like having an entire industry which is designed to treat failures. And the fact that that industry exists is stunning. Now, what is also happening on the neurosurgical front is these guys are getting really good at doing the minimally invasive decompressive surgery. And the ones that are doing it are getting, and I've seen it where I send people and I see their spines, they look like they've gone in reverse by 20, 30, 40 years, where they simply don't have any of that without fusion. It's shocking. It's beautiful. It's poorly reimbursed by today's reimbursement structure, so most people are just really not interested, neurosurgeons and the like. So it's really not that available, and that's why all these things exist. Endoscopic spine surgery is a way to go about it. Some of the best endoscopic spine experts are outside the US because they can do it out there. The cowboys sometimes have to grow in wild places, and that's where you grow them, because the US is so risk adverse at this time. But nevertheless, that's me rambling a little bit. If you are interested in these kinds of devices, talk to your interventionalist. If you are further interested, you can't find someone, I'm willing to educate you on your options. If you want to come and be a patient, it means you need to come to Florida and me assess you, because I practice medicine in Florida, but I do education around the world. So reach out. I hope this has been good for you and you've learned a little bit about what's available. I'm encouraged, and I hope you are too. I'm William Porter McRoberts, MD. I do interventional spine, interventional pain in South Florida and Fort Lauderdale. Thank you for your attention. God bless you.